Good morning. Welcome to the Specialized Recovery Services Program Eligibility and Expedited SSI SSDI webinar. We're very happy that you're with us this morning. My name is Kim Donica, and I will be kicking us off this morning. This webinar will highlight eligibility changes as a result of Ohio's Disability Determination Redesign, the Specialized Recovery Services Program and referral processes, as well as information about the Expedited SSI SSDI program. My colleagues, Amy Knuff, Daniel Damaski, and Michelle Reinhart are with me this morning to give you some, I think, informative and exciting information about changes that happened within the Medicaid program as of August 1st, along with very useful information about expedited SSI and SSDI programs. So before we get started, let's do a little housekeeping. This webinar will be recorded and posted at www.bh.medicaid.ohio.gov later this week. A newsletter will be sent when it's posted with a link to the recording. We will have a short Q&A session following each section, which will be cut off at the end of the session to ensure ample time. We have a lot of really good information to share with you, and we want to make sure we get it all in. Please enter your questions using the question function that's available in the WebEx. There will be an extended Q&A session at the end of the webinar. Any questions we do not get to will be answered electronically after the webinar. So let's get started. We're going to start off actually with our agenda. We did our housekeeping, then Amy's going to talk with us a little bit about Medicaid eligibility updates. We're going to have Dan and Michelle talk about expedited SSI and SSD, and then we're going to end with me talking about the Specialized Recovery Services Program. And for those of you who have heard me talk about this before, I apologize. Maybe we'll mix it up a little bit and do something a little different or a little exciting. Okay, so we want to start off by just giving you a bit of an overview on the process, and to take a case example. We think that it might be helpful if you all have a person in mind as we're walking through this information. And so in this slide, we have what we would describe as the typical eligibility process for SRS referrals. In this scenario, the individual is 35 years old. They do have a diagnosis of schizophrenia. The individual is receiving care from a fabulous behavioral health provider. This person was on spend down. They have an income of $1,800 a month, and they spent down to receive their Medicaid coverage prior to August 1st. And one of the things that we're going to talk about today, obviously, is the elimination of the spend down program and what that means for people. In this particular scenario, this person is required to enroll in the SRS program in order to maintain their Medicaid eligibility after their redetermination in April of 2017. So if we look a little bit at our timeline, what we can see here is, again, this was a person who was on spend down. They were spending down in order to gain access to their Medicaid. This is a person who was actively engaged with the behavioral health provider. That provider actually identified this individual as being potentially eligible for the program. Because this person had met their spend down in any month in the 12 months prior to conversion, they were converted to full Medicaid as of August 1st. We did then get a provider referral for this individual for the SRS program. They were randomly assigned to a recovery management entity in their region and began their SRS process. As you can see in this timeline, we also indicate our pause on ABD redeterminations between August of 16 through January 1st of 17. And so individuals who were spin down, who got converted, they need to get enrolled in the SRS program by their 2017 redetermination or risk losing their Medicaid coverage. And I really can't emphasize this enough. It is very, very important for individuals and for the providers who are working with them to make sure that folks are getting referred to the program, as this is their gateway to their Medicaid coverage. And I know that we all want to maintain that, obviously, particularly for providers who bill Medicaid for the services that they render to people. So the SRS process begins. The recovery manager performs an assessment. The individual meets the criteria for SRS and is enrolled in the program. And then when their redetermination happens in September, all is well. Their coverage continues because the person is in fact enrolled in SRS. And so that is kind of the typical pathway. And we're going to revisit this pathway throughout the presentation just so that we can highlight the steps in the process to get folks enrolled. So here is the process for an expedited SSI or SSD and SRS referral. So in this scenario, we have an individual, a younger individual, 21, again has a diagnosis of schizophrenia, has had 2 hospitalizations for a psychiatric condition since 19. They were referred for services in the community mental health system during their 2nd hospitalization, and that mental health agency is also an FQHC and qualified for a presumptive Medicaid application, and it just so happens, Christmas miracle, they're also an expedited SSI and SSDI site. So in this scenario, we have an individual who gets presumptive eligibility and a full Medicaid application for Group 8 Medicaid. And so that happens. But at the same time, then, the assessment and the data collection for SSI and SSD happen right away. And this, in our mind, is really a best practice, where you're simultaneously supporting an individual with the Group 8 Medicaid application and also starting the expedited SSI SSD process. Then the Group 8 Medicaid is established, woohoo, and the person is identified as appropriate for that expedited process. And as Michelle is going to talk about, you know, not everybody is appropriate for that process, but she's going to tell us everything we ever wanted to know so that we know that the referrals that we're making are appropriate. So in month 2, then we would expect that that expedited SSI application would happen. And in month 3, woohoo, the SSDI is awarded, and it's based on the retired parent's account. And income is above what we would call in Medicaid world the needs standard. So what happens with these Group 8 folks who get SSI is, you know, after 20 months, the individual is going to get referred for SRS because they don't get their Medicare right away, right? So there's a waiting period, essentially, between the time that they get approved for their SSDI and they get their Medicare. And so during that kind of 20-month period, they're on Group 8, they're getting their Medicaid, life is good. But what's going to happen is once that person gets their Medicare, they're no longer going to be eligible for Group 8. Because this is a person that we've identified as being above kind of the typical Medicaid needs standard, we're going to need to get their Medicaid eligibility under another category, that category being the Specialized Recovery Services Program. And so we would like and we would expect that providers would be tracking this, making referrals around that 20th month so that we can get that individual assessed and enrolled in the program by the time their Medicare is established so that they don't lose their Medicaid coverage. And again, it's a seamless experience for the individual. So that just gives you kind of a couple of case examples, and like I said, we're going to use those throughout the presentation to help give you some context around the information that we're providing. I'm actually going to pass the mic off to Amy, who is going to talk about Medicaid eligibility. Woohoo!
Okay, good morning everyone. So now we're at the part of our timeline where Medicaid eligibility is established. So I'm going to give some updates on our Medicaid eligibility rules and some of the changes that went into effect on August the 1st. So this slide here just gives an overview of the 209B law, but we're not going to go over the details of this morning, but you have this here for your reference if you want to look at that a little more closely. So when Ohio was a 209B state, which of course was prior to August the 1st, the order in which Medicaid eligibility was explored for an individual was that first we looked at our MAGI categories. And we use MAGI budgeting. There's no resource test for MAGI. An individual could be open on MAGI and in a long-term care facility, but they couldn't be on a waiver. And our SSI individuals could also be on MAGI. If the individual did not meet the eligibility criteria for MAGI, we then moved on to look at our age, blind, and disabled Medicaid category, which is also known as ABD Medicaid. And there are different eligibility criteria for ABD than there are for MAGI. So there are deeming provisions for income and resources. The income limit was 64% FPL, which is $643 for an individual or $1,100 for a couple. And they did have the ability to spend down their income to become financially eligible. The resource limit was also at $1,500 for an individual and $2,250 for a couple. Now, when we look at the changes that took place on August the 1st, we do have to look at Section 1634 of the Social Security Act. And this section stated that the states can enter into an agreement with the federal government and use Social Security to determine Medicaid eligibility for individuals who are receiving SSI payments. Now, under this section, individuals who are found eligible for SSI are automatically enrolled into Medicaid and don't have to apply separately for Medicaid benefits. Ohio's transition from a 209B state to a 1634 state simplifies the Medicaid eligibility determination process by eliminating that need to apply separately for SSI and for Medicaid. And of course, our spend down option no longer exists, and the income and resource limits increase to match the SSI income and resource limits. So on this slide here, you just have the new income limits that went into effect on August the 1st for our ABD categories. The individual limit increased to $733. The couple limit actually stayed the same. And also, we don't have a resource limit listed here, but that did increase as well to $2,000 for an individual and $3,000 for a couple. And this slide here lists the three major changes that took place on August the 1st. We're not going to go over them here on this slide because we're going to go over them in more detail on the upcoming slides. So first, let's talk about the auto-enrollment of our SSI individuals. Okay, you can go to the next one. So Social Security, they're already going to verify the income and resource limits and other eligibility factors such as citizenship and residency, and Ohio is going to accept that decision. The SSI beneficiaries will be automatically enrolled into Medicaid, and the county offices should only be verifying that that individual is in receipt of SSI payments. Now, the SSI payment begin date is going to determine the begin date for Medicaid for that individual. If retro eligibility is needed, the individual would actually have to apply separately for that retroactive coverage if it's needed before August the 1st. So another big change with the disability determination redesign is that as of August the 1st, the spin down option no longer exists. Individuals who now have income which exceed the new income limits for ABD will be referred to the federally funded marketplace to shop for coverage. Now, we understand that individuals with Medicare won't be able to purchase coverage through the FFM, so they will have to work with Medicare to see if there's a supplemental plan that might be an option for them. Now, we do still have some Medicaid options for individuals with disabilities, and these include our MBIWD program, which is for disabled individuals who are working. We have our residential state supplement program. You can obtain more information at the website listed at the bottom of the slide. And of course, we have our new SRS program for adults with severe and persistent mental illness. Now, although the spin-down Medicaid no longer exists as of August the 1st, the Ohio Department of Medicaid has extended coverage for age blind and disabled individuals who met their spin-down in any month between August 2015 and July 2016. These individuals will continue to receive active Medicaid coverage until their next Medicaid renewal unless they have a significant change prior to their scheduled renewal. At their scheduled renewal time, their eligibility will then be determined based on the new Medicaid rules. Now, you can find some more information on this in MEPL 115. If an individual did meet their spin down between August 2015 and July 2016 and the county office processed their spin down prior to August the 1st, the individual should have been automatically placed on Medicaid on August the 1st. However, if the individual did not provide documentation to the county office to meet their spin down prior to August the 1st, they still have the option to do so. The individual must provide to the county office valid documentation within 365 days of the date of service showing that their spin down was met between August 2015 and July 2016. The county office will then open coverage for the month the spin down was met and manually open Medicaid coverage effective August the 1st. We want to make sure you are all aware that this option exists in case you have an individual who was previously on spin down Medicaid. Go back one. In addition to extending coverage for individuals who met their spin down in the last 12 months, in the 12 months prior to August the 1st, renewals for all age blind and disabled eligibility groups have been deferred until 2017. However, there are certain instances when a renewal would be required during this deferral period. We're not going to go over each of these instances this morning, but they are listed here on this slide for your reference. We also want to remind everyone that if you're working with an individual and you're their authorized representative, you can obtain the individual's Medicaid renewal date from the county office. The individual's renewal date can be used to gauge when the SRS referral should be submitted for the individual, which again we do recommend completing 4 months prior to the renewal date. Additionally, for our Group 8 individuals who are receiving SSDI and are in that 24-month wait for Medicare, we do recommend completing that SRS referral again 4 months before their Medicare starts. And other changes that were implemented with the disability determination redesign on August the 1st are surrounding Medicaid's disability determination process. The big change in this area is that Social Security will now determine disability for Medicaid, and there are only a few instances when the Ohio Department of Medicaid will still determine disability. Those instances are when an individual is potentially eligible for retroactive coverage due to being deceased, Alien Emergency Medical Assistance, also known as AEMA, or MBIWD. Now, for MBIWD, Medicaid will determine disability if the individual has not already been determined disabled by Social Security and their income is above the significant gainful activity limits. And the last topic that I'm going to discuss today is the pre-termination review, which is also known as PTR. Now, a PTR is basically an eligibility review, and if an individual is no longer eligible for a category of Medicaid and the termination of that category is being considered, the worker must explore eligibility for all other Medicaid categories. If eligibility does not exist in another Medicaid category, then Medicaid can be terminated and the individual's case can be closed. However, the individual must be given prior notice of the termination, they must be allowed due process and hearing rights. As you can see, we've listed the relevant OAC policy sections here on this slide for your reference, And if an individual is found to be ineligible for all categories of Medicaid, but they are in the SRS assessment process, their Medicaid should remain open until the SRS assessment process is complete. And that is all I have on eligibility updates for you today. If you have any questions, you can go ahead and type those in for us.
So our first question was about can an SRS application be done online? And the answer to that is no. And we will talk further in the presentation in probably more detail than you ever wanted to know about how those SRS referrals are to be done. But the application itself is not available online. Additionally, I think we had a question regarding spin down and how long spin down was in effect, and so I'm going to turn this over to Amy to answer.
Okay, so we have our question here. Everyone who qualifies for SSI will be automatically enrolled into community Medicaid. And there was actually a new Medicaid category created for our SSI individuals, and it is a category specifically just for our SSI individuals. But yes, they will receive the same Medicaid benefits as community Medicaid. So yes, that would be correct. So we have another question here, and it's how much prior notice does the customer receive before Medicaid is terminated? So they are required to receive at least a 15-day notice. So that is around the middle of the month. So it's about a 15-day notice, and it kind of differs each month. So they would have, if the county office terminated their benefits on October the 8th, they would have, their benefits wouldn't actually close until October the 30th. However, if they terminated their Medicaid on October 22nd, their Medicaid actually wouldn't terminate until November the 30th. So they do have to give them at least a 15-day notice before their benefits are terminated. Okay, and our other question here is asking for us to repeat, and did you say base Medicaid would stay open while a person is going through the SRS determination? And yes, that is correct. The caseworker would have to know they are going through that SRS assessment process. So if you ever run into a situation where an individual who's going through the SRS assessment gets their Medicaid terminated, you'd probably want to try to reach out to the county to let them know about that in case there's an instance where maybe they weren't aware that they are going through that assessment process. So we're going to go ahead and close the questions for this portion of our presentation. You can still submit those, and we will answer them all electronically at the end if we can't get to them. So now I'm going to pass it on to Dan to talk about our Expedited SSI and SSDI overview.
All right, well, good morning. So where we are in the timeline here is about towards the middle, so when a person would submit an application for SSI or SSDI, and how we handle the process in the local office. So we'll kind of give basically an overview of the eligibility requirements for SSDI and SSI. We'll talk about the process of how to file an application for the expedited process, and then the back end when we get applications back when they're decided by our disability office, and then we'll talk a little bit about online services as well. So as I mentioned, we'll talk about the SSDI, which is Social Security for workers based on a person's contributions into Social Security. We'll talk about Social Security for adult disabled children based on a parent's record, and then Supplemental Security Income, or SSI, which is a needs-based benefit. So our standard definition for disability is a person must have a physical or mental impairment or a combination of impairments that basically make him unable to perform substantial work, which this year we consider substantial work $1,130 in gross wages per month for a non-blind individual, and there's a higher threshold for blind individuals. So if a person's blind, that threshold's $1,820 in gross wages a month. So our standard definition is a person must have a disability that's expected to last at least 12 consecutive months or end in death. And we also factor in their age, education, past work activity. So Michelle will go into a little bit more than that, so I don't want to steal her thunder, but that's kind of going into the definition of disability. So first we'll talk about the SSDI, or Social Security Disability Insurance Program. So this is based on a person's work and contributions to Social Security. So a person's income and resources don't affect eligibility. So if a person has $1 million in the bank, that's A-OK for SSDI. That doesn't affect this at all. Income, if they have short or long-term disability, typically won't affect it. If they have wages, they're still working, that's where that substantial limit of $1,130 will come into play. But if they have other income, whether it's short, long-term disability from work, that's fine. You have to have recent work paid into the system. So for most adults, it's typically 5 out of the last 10 years they have to have paid into the system before they became disabled. So that's where that 20 credits in the last 10 years comes out. If you're a younger person, there's less credits, and we'll go into that in a moment here. If a person is approved for SSDI, they can get benefits retroactive up to 1 year from the point they file their application. So if a person's contemplating filing for benefits, it's to their best interest to file as soon as possible, because if they get approved, then we can go retroactive up to 1 year to pay them benefits, assuming they were disabled a year in the past. In addition, if they're approved for benefits, their dependents can be paid benefits under their records. So if they have minor children that are still in school, if they have a spouse who's taking care of these minor children and not working, they could potentially get benefits as well. And the disability benefit is essentially like getting your full retirement benefit early, with the understanding being you can't work, so you're going to get your full benefit early based on the fact you have a disability. In addition to SSDI, Medicare comes with this provision of benefits. There is a 24-month waiting period for Medicare, and that 24 months starts from the point benefits begin. So for example, if we can go back up to 1 year to pay a person benefits, then the person's Medicare will begin 12 months from now. Now there are some provisions that a person can get Medicare much sooner without waiting for that 24-month waiting period. For example, if a person is diagnosed with ALS or Lou Gehrig's disease, or if they undergo kidney dialysis or kidney transplant for end-stage renal disease, those folks don't have these 24-month waiting periods, just for those two conditions. And we have provisions as well for assisting folks to return to work. So the biggest thing when people get SSDI, if they go back to work, is to report it to us so we can kind of keep tabs on it. But we actually encourage disabled folks to try to go back to work. So we have provisions to assist them that they can still get benefits for a period of time while they attempt to go back to work. So we'll talk about the credits that you need paid into the system to be eligible for SSDI. So as I mentioned, for most folks, or most adults over age 31, you typically need 5 out of the last 10 years before your disability began to be insured. So I kind of tell folks, think of SSDI kind of like car insurance. If you're currently working and paying into it, you're going to be covered. If you stop paying into it, eventually your coverage is going to lapse. So for most individuals, the coverage will lag about 5 years after they stop working. So if they become disabled a couple years after they stop working, if they've had worked at least 5 out of the last 10 years prior, they should still be insured for SSDI disability. So for a younger person, obviously, if you're 20, 21 years old, you don't have 10 years to have those 5 years paid into the system typically. So for younger folks, typically you just need a few years of work. So for example, if you're under the age of 24, you just need 1.5 years of work, or typically 6 credits to get paid into the system and be insured. If you're between 24 and 31, then you just have to work half the time between the age of 21 and the time you became disabled to have enough credits. So when you work and pay into Social Security, you pay taxes, obviously, the FICA tax and the Social Security, and you can earn a maximum of 4 credits per year. The credits are based on a person's wages if they're employee, or if they're self-employed, their net taxable earning for the year. So each $1,260 in earnings gives you 1 credit. So a little over $5,000 will get a person all 4 credits for this year. Now whether you make over that $5,000 or $5 million for the year, it's the same. You get 4 credits. So that kind of gets your foot in the door. Obviously, a person makes more and pays more into the system, they'll have a higher benefit than someone who paid less. But that's the floor. So if that person gets 1,260, they get some 1 credit for the year. And this amount typically does change a little bit every year. So next year, I could just guess maybe closer to 1,300. I mean, not 1,300 exact, but close to that. So typically, it does increase a little bit every year, these credits. And the amount of a person's benefit is based on their entire work history. So for example, if a person is closer to their retirement age, they're probably going to get more close to whatever their statement says from Social Security, as opposed to someone who's younger. We're kind of, for that younger person, we're going to project that they may be continuing working and earning for the next 20, 30 years and going on a pretty steady upward incline in earnings for the rest of their career. So a younger person's benefit, even though on paper they may have made less money than a person who's older, because we're making this assumption that they have 20, 30 years ahead of them to continue working, they actually may get a higher benefit than someone who may be, for example, older, who has those 20, 30 years already paid into the system. And if a person's benefit from the SSDI is lower than the full SSI payment, then that's where the person can get both SSDI and SSI to kind of bring them up to the full SSI rate if they have paid very, very little into SSDI. So we'll talk for a second about SSDI benefits for adult disabled children. So this is for basically a child who was disabled before they turned age 22, and maybe they don't have enough credits paid into the system on their own work history. But if they have a parent who is either disabled, retired, or deceased, and this child is found medically disabled before they turn age 22 and not married, they can claim benefits off of their parent's record, who again is either disabled, retired from Social Security, or was deceased and had credits paid into the system. So next we'll talk about the SSI, Supplemental Security Income Benefit. So this is basically a last resort benefit. So a person, to be eligible for this, has to have limited income and limited resources. In addition, the person either has to be found blind or disabled, or at least age 65. So with SSI, because there are income and resource limits, for example, for an individual, the resource limit is $2,000. For a couple, it's $3,000. Now, there are some things we do count and don't count. So things that we do count for these limits for resources are a person's bank accounts. If they have excess automobiles, so a second car, if they have a car lot behind their house, we would count those excess cars. If they have stocks, bonds, 401ks, retirement funds, liquid assets, additional properties, so if they own 3 or 4 properties or vacation property in addition to their primary residence, then we're going to count those excess properties as resources towards these limits. So this is kind of where we get into saying this is a benefit of last resort, that you kind of have to go through all these other things, liquidating these things, or kind of selling off things before you can be eligible for SSI. But we don't count those individuals' primary home they live in. We don't count their first automobile. We don't count a burial plot. And if they have resources set aside for paying for a burial spot or burial funds, we don't count those as well. So these are some things that we don't count that could affect SSI eligibility. So now we'll get into how to apply for the SSDI and SSI expedited process. So the way you apply for the SSDI would be online at www.socialsecurity.gov/apply-for-disability. So we do not have the SSI portion of the application online yet. That will be coming hopefully here in the next year or so, that we can kind of have everything under one application. But as of now, this is the process. So you apply for the SSDI online, and then you would do a paper application for the SSI, Supplemental Security Income, on a paper SSA 8000 form. So this is the first step of the process. So when you do the SSDI portion of the application, you will do the application for SSDI, and then you will do the medical report on there as well. So that's where you'll enter a person's doctors that they've gone to see for treatment. You'll enter names of medications, types of treatment they've had done in the past. So that's the part that may take the most time, is doing the SSDI online. But the great thing about doing it online is you can start the application, jot down the reentry number. If you have to stop, put it down, go back to it later. As long as you keep that reentry number, you can go back online and complete the application at your leisure. So when you've done that application for the SSDI online, you'll do the SSI application on paper. Once you submitted the SSDI, then you'll submit all this in a packet together. So the packet you're going to submit is going to complete, there we go. So you're going to complete a medical release form, which is the SSA 827. So that can be done electronically online. or if you haven't done it online, you can do a paper form having the person sign it, a wet signature. In addition, the SSA 1696, which is the appointment representative, and this would give you as a case manager access to their file while their case is pending. So if you had questions, if you have this form on file in the person's case, then you can call on their behalf and ask any questions or submit documentation as well. And if a person is not capable of handling the finances, there's a couple additional forms that you could submit to be their representative payee. So if a claim is allowed, what happens is a award notice is sent to the client. It kind of explains when their benefits are going to start, the benefit amount, information they need to report to us, for example, work activity, if they have medical improvement. It'll also tell them based on their case when they can expect that it will be reviewed. So everyone that gets SSDI or SSI eventually will have their case reviewed. It's more funding driven, so it could be every few years, it could be even longer. And if a point representative is on file, then they'll also get copies of all documentation. So it's important to have that on file if you want to assist this person through the case process. Now, if the case is denied, they'll get a letter explaining how they got to that decision. It gives them 60 days to file an appeal of the denial letter, and it also to update any information with us. So the appeal process is primarily done online, so it can be done on paper as well, but it's recommended to do online because you can do it the same day. It's pretty quick and easy. So you go to socialsecurity.gov/disability/appeal to do the appeal process. So it's pretty simple. You're going to input the reason why you disagree with the decision. It could be very brief. It doesn't have to be too exhaustive explanation. The next portion is going to be the medical reports, the appeal disability report, form 3441. This is going to ask for any updated medical information from the time that the initial application was filed. So if you went to new doctors, if you had new treatment, new medications, you're going to input this information here. Now, if there was no changes, everything's more or less the same, then it can be a pretty brief and quick application to do. In addition, we'll ask for a new medical release form because the medical release forms we have are only good for a year. So if it's been several months since the initial claim was filed, then we'll typically ask for a new medical release form. So briefly, we'll talk about My Social Security. So this is a portal to get access information. This could be for yourself. It could be for your clients. It's a portal to access information on your own record online. So to be accessing your own information, you must be at least age 18, have a valid email address, a Social Security number, and a mailing address to access and set up this account for My Social Security. So when you go on there, it's kind of similar to checking your credit report, so it's going to ask you some very personal questions. So for folks that have been, for example, transient, moving around a lot, it's going to ask where have they lived in the last 5-10 years, an address, if they know how much their car payment was, if they have a mortgage payment. So if they don't have those types of things or they're moving around a lot, then maybe registering online is not the way to go for this. And there's another way around that. You can have the person come into the local Social Security office with their ID, and we can basically pre-register folks to get around these tricky questions, which for most folks, they may not be a problem to get through. But for someone, like I said, has been transient, they haven't had a stable address, or they haven't had, for example, mortgage history that we can draw upon for these credit reports to verify the person's information, then they can just go to the local office with their ID. We can pre-register them. In some offices, we even have self-help PCs that they can actually have someone assist them set up their account in the office. But once your person's in there, if you don't get benefits, you can print off your Social Security statement. So we used to mail these yearly. Now they come every few years. But you can get it online, your most recent statement. If you do get benefits, this is where it gets a little bit better, that a person can verify their benefit online, so they can get a verification of benefits, print off an income verification. They can see their benefit amount. They can see their earnings record. They can update address, telephone number, direct deposit. If they get Medicare and lost their Medicare card, they can request a replacement Medicare card through here. And pretty soon, you can replace your Social Security card through here as well. So some states around Ohio have that, but Ohio hopefully will be getting it here in the next several months. And once that's on there, that's a game changer that folks can request this online without having to come into the local office. So that's all I have. I will pass it off to Michelle here, and then we'll get to questions after she's done.
Hi, good morning. I'll be talking about what happens to your client's claim once it comes to our office. Very quickly, there's some different terminology that you might hear in reference to my agency. DDS, Disability Determination Service, this is the general name that Social Security gives to the agency for a particular state that processes the Social Security disability applications for that state. And then DDD, or Division of Disability Determination, that's what we call ourselves. I know there can be some confusion there, but either term means my agency, so you're good there. Okay, so what happens when the claim gets to my office? We have a department that takes care of all of the claims that come in. They receipt the claim in and note any special flags. And as far as getting your client's claim with that special flag, the first step in doing that is contacting MHAS. You'll email them, and I will give you that email address later in the presentation. And they will walk you through the process and also ensure that it gets the special flag so it makes it to my unit. I do monitor a queue every day, and I assign the claims to an adjudicator within the homeless unit. So the adjudicator then will review the application and request all of the medical evidence from the relevant treating sources listed on the application. We may determine that an examination is needed from one of the doctors that we work with throughout the state. And then once all of the records are in, the adjudicative team, which is it consists of the adjudicators, our medical consultants, and we have physicians, psychologists, speech and language pathologists. We have a radiologist on staff as well as an ophthalmologist, along with any disability claims specialists who would essentially give us advice about maybe more tricky vocational issues. They work together to analyze all of the available evidence. Then the adjudicative team is going to determine if your client has severe and marked limitations that meet SSA disability guidelines or that prevent all work-related activities. And then once the final medical determination is made by my office, typically the claim goes back to the local Social Security office or field office, and your claimant will be notified of the decision. Some claims are randomly chosen for review by Social Security's Quality Assurance Department. That typically runs about 10% of all the claims that leave our office. They review it. If they agree with our decision, they then release the claim to the local office. If they don't agree with our decision, they send it back to us and let us know what steps we need to take. We do that, and you'll know that because we will be letting you and your client know that the claim is back with us for some additional work. So very quickly, what is disability? And this is Social Security's definition of disability. It's the inability to engage in substantial gainful activity or work, and Dan gave those amounts earlier, due to a medically determinable impairment, and that can be mental or physical impairment that's expected to or has lasted a full 12 months or is expected to result in death. And the important thing to take away from that is that Social Security disability is permanent, it's long-term, and it's full disability. It doesn't follow the VA where there's a percentage of disability. It's kind of an all or nothing thing with us. So the way that we evaluate each and every claim that comes through our office is the 5 steps of sequential evaluation. It's the roadmap that we use for every claim. The first question that we're going to ask is the claimant engaging in substantial gainful activity? 99% of the time, the answer to that is going to be no. Sometimes a claim does get through to us where the claimant has either started working since they applied for benefits, or it wasn't clear when they applied at the local office that their work was at the SGA level. So we always just kind of do a quick check to make sure that that answer is still no. If it is yes, then it'll go back to the local office. Does the claimant have a severe impairment? All that we mean by that is, does their physical condition, their psychological condition, or a combination of the two result in more than a minimal impact in their daily functioning? And if the answer to that is yes, then we continue. If they don't meet the requirements for just a severe impairment, or if it's clear that the condition is not going to last the full 12 months, we would then return it to the local office. And some ideas about things that maybe won't last 12 months are for broken bones, things like that, things that are expected to heal within that 12-month period. So next we're going to look at, does the impairment meet or equal the listings? And the listings are completely public information. You can find that on SSA's website. If you go to ssa.gov in the search bar at the top, if you just enter the listings, it will bring up essentially what we look at for every impairment. So to meet the listings, if it says you have to have A, B, and C, you have A, B, and C. To equal the listings, the best way to kind of put that is maybe you don't have A, B, and C, but you have D, E, and F. the severity is the same, the impact is the same, so we are able to make a medical determination that we can allow you and you meet the listings or equal the listings. If you don't meet or equal the listings, we then look at what can your client still do despite his or her impairments. For physical, we have something called a residual functional capacity form. We just talk about what can they do physically, how long can they stand, sit, walk, how much can they lift, how can they use their body to essentially engage in work activities. And for psychological impairments, we have a mental residual functional capacity form. And what that does is we just look at their persistence, their pace, how are they able to get along with others, how are they able to follow instructions in the workplace, as well as are they able to sustain work over a 40-hour work week. So if once we have the RFC and MRFC, we look at, does that prevent your client from going back to any of their past work? Typically, we're going to be looking at the past work for the last 15 years. If we find work that they've done in the past that they can return to despite their impairments, then that would be a denial at step 4 of sequential evaluation. If we can't find any past work that they can still do despite their impairments, or if they don't have any past work, we then look at does their impairment prevent other work? So we're going to look at the national economy, and at that point we are looking to see, are there other jobs in the national economy that your client can do despite his or her impairment. If we can find jobs, and we're typically looking at about 3 jobs that we could find in the national economy that they can still do, if we can find that, then it is a step 5 denial. If we can't, then we would make a determination. We would allow the claimant at step 5. And just real quickly, the physical listings, you can see that we break it down by body system, everything from musculoskeletal, which would be your joints, your back, neurological, cancer, immune system disorders. And then the mental listings gets their very own listing, and we break it down essentially according to the impairment. So schizophrenia, paranoid, and other psychotic disorders. Affective disorders, that's where we're going to be looking at major depressive disorder as well as bipolar disorder. Anxiety-related disorders, that's generalized anxiety disorder, anything that would fall kind of under that category, personality disorders, substance addiction disorders, and then autism and other pervasive developmental disorders gets its own section of the listing as well. So the role of the health professional, basically what are we looking for from you? Assisting your client completing any questionnaires or forms that they would receive from my office, sending medical records that maybe they may have access to or that you have access to, giving descriptive information about your client's functioning, their response to any treatments. And while only certain treating sources are considered acceptable medical sources by SSA for decision making, all medical information is extremely valuable to the claim. So what is an acceptable medical source? For physical impairments, we're looking for doctors, physicians, MDs, or DOs. For psychological impairments, we can accept psychiatrists, psychologists, and that would be a PhD or a PsyD. And then for childhood-related impairments, school psychologists for intellectual disabilities or other learning disorders. For speech and language disorders, it's going to be speech and language pathologists. And then just other good sources of information, mental health counselors and therapists, social workers, case managers, hospitals and clinics, rehab centers, and schools. So the big takeaway from that is just because you may not have a PhD or a PsyD behind your name doesn't mean we want the information from you. You serve a valuable function, and quite often the social workers, case managers, and clinicians have great information about how that client is truly functioning. So what are we, oh, sorry, back one. Thanks. So what kind of information are we looking for? We're looking for dates of treatment, diagnosis, a capability statement if you happen to have that, testing and imagery results, op reports and path reports for physical impairments, office notes, any mental status exams that you may have access to, inpatient and ER records, psychological testing, especially if you have someone who is alleging a developmental disability or if like a traumatic brain injury, something like that. If there is psychological testing available, we would love to have a copy of that. And any information you have about the functional limitations due to symptoms, as well as functional limitations due to the effects of the medication. So what might we need from your client and or you? We may need to have you help get your client for an examination. Perhaps we might need you to contact sources for assistance in obtaining records, and we really only ask for that if it's a critical source, if it's information that we truly need to make sure that we're making the correct decision on a claim and we are not able to get it despite our initial request and then the follow-ups that we make. We may have your client reach out to their doctor's office and say, hey, disability is trying to get this information from you. Could you please send it? We also recommend that as your client starts going through the process of applying for benefits, that he or she let their treating sources know that they are applying for benefits so that they are looking for our request and they've kind of got that in mind that it could be coming. And then forms, the MHAS forms, a work history form that we might send out, and then if we need updated medical releases. So kind of other general issues, please be sure to include all allegations on the application. Your client may think that one thing in particular is what is disabling to them, but we want to know pretty much everything about them, any physical or psychological impairments that are present, because we do look at the full person and we look at a combination of physical and psychological impairments. If you are supplying records, please be sure to include the entire record for the relevant time period. So just as a general rule, for SSDI, we're typically going to request records 1 year prior to the alleged onset date. Typically, that's the date when your client stopped working. For SSI, we typically are going to be requesting records 1 year prior to the application date. Okay. A diagnosis does not equal a disability. We're a function-based program, and it's the severe limitations in functioning that would lead to us being able to find your client disabled. A great example of that is your client has diabetes, but it's controlled with medication, and they have very limited effects on their functioning. Prior allowances, just because somebody was allowed in the past doesn't mean that they'll be allowed again. The listings may have changed. The person may change in age. The severity of the condition may have changed. Maybe they've improved. Or there may be technical denials. So this is just a list of the adjudicators in the homeless unit. So once your agency is linked with the MHAS program, you should be seeing one of these people's names on any correspondence that you get from my office. Okay, and then some other useful resources, just a couple websites, ssa.gov, and then the most important one is the MHAS Expedited SSI Program. If you are interested in being a part of this program, you should contact them via email at expeditedSSI@mha.ohio.gov, and they can talk to you about the process. They'll also be providing additional training. And just real quickly, the benefits of being part of this program is your client's claim will receive expedited processing at each step of the process with the local field office as well as at my office. You as the authorized rep will receive copies of all of the correspondence from the field office as well as my office. That also allows us to talk with you about your client's claim with us, and it will come to my unit. So it's a dedicated group of adjudicators who are highly trained and well-versed in the unique needs of your client base. So that's it for me, and it looks like we have some questions.
All right, so one question we have, if a person is going through the application process for SSI, SSDI, but has not been approved yet, is their application status or appeal status available online on the account? It is, and you can also get it without an account. So when a person files an application, they can request essentially a confirmation number that they can go online to see if the case is still pending. Now, it's not going to give a whole lot of detail. Unfortunately, it's just going to say the case is still pending. So if you want to know it hasn't been decided yet, that's essentially what it's going to tell you. If it was decided, it'll tell you the case has been decided. It won't give you the decision one way or another. It's just going to tell you the case was decided. Another question was, how does this differ from SOAR? So SOAR is more along the lines of homeless. Another question in that same vein is, why are these cases being flagged as homeless if they're not homeless? The reason why they're flagged as homeless is so Michelle gets it to the right person, the adjudicators, and essentially that expedites the whole process for us. By flagging it on our side of things homeless, it gets to Michelle, and she gets it to the correct adjudicator, so we can make sure we get the process sped up as much as possible along the whole way.
And question is, I thought SSA had stopped approving disability for substance abuse related disorders, but I see it's back on this list. You are correct. We will not approve someone just for substance abuse related disorders, but we do understand that quite often people do use drugs and alcohol. Often they're self-medicating. So we do evaluate it within the claim. I do encourage you, if you have someone who is using, please do not be afraid to say that. Typically we will discover that within the records anyway, but we do look at it, and we understand that, especially, you know, with some of these more severe disorders, the self-medication is kind of what helps them get through the day. So it's not going to be an automatic denial because your person is using, but if all that they're doing is using drugs or alcohol and that's their only impairment, then most likely it's going to be a denial for that. But again, always include everything, and if they are using, that is completely okay. And then just to kind of piggyback on the why is it being flagged as homeless if they're not homeless, that flag is just kind of a general flag for any of our special projects, so that it's just something that the field office has determined is easy to use, easy to remember, and ensures that the claim gets to my office and gets to my group.
Thank you very much, Dan and Michelle. That was very informative, and I'll tell you what, I wish I had heard this presentation 20 years ago, because I think, I'm showing my age, I think it would have helped me tremendously. So that was fantastic. Okay, so moving on, we're going to talk about the Specialized Recovery Services Program. Toodoo! I feel like I should have a little horn. This is Kim Donica again, and we're going to start off by revisiting our timeline. So I think that everyone did a terrific job kind of explaining the importance of the process and getting disability established, particularly for new individuals who are new to their disability and new to the delivery system, how the process works with presumptive eligibility and getting Medicaid through Group 8, applying for and getting disability established, the waiting period prior to Medicare eligibility, and then the need to really track these folks so that we can make the SRS referrals so that individuals can have no disruption in their care and in their services when they no longer are Group 8 eligible because they are receiving Medicare. So great job, everybody. And so now we're going to talk in a little more detail about the Specialized Recovery Services Program. Now, I know that you all love to read Ohio Administrative Code in your spare time. I certainly do that, and so if y'all want to go, and I know I'm a nerd, let's just face it, if y'all want to go and look at Ohio Administrative Code 5160-4302 to review the Specialized Recovery Services Program Individual Eligibility and Program Enrollment Rule, I certainly encourage you to do so. But I'm going to give you the Reader's Digest version today. So let's revisit our typical eligibility process for SRS referrals, because this is really what is happening typically for people. We have individuals who were on spin down prior to August 1st. and who got converted to full Medicaid because, again, they met their spend down in any of the 12 months prior to August 1st. And as Amy pointed out, even if you have folks who did not provide documentation of meeting their spend down prior to August 1st, they still can. So if you have people who you provided services to, who you know, you can demonstrate that they met their spend down, I really, really encourage you to go ahead and submit that to the county and to work with folks to get that eligibility established. I think that it is a lot of folks aren't aware that that's an option to people, so I'm just going to give a little plug for that. But again, we are really relying on providers, on our community behavioral health community partners to help us identify people who could benefit and need to be enrolled in the Specialized Recovery Services Program. And so we're going to talk in detail about who's eligible, what the process is, what is this thing, Kim, that you're talking about called recovery management, why are these names so goofy, and hopefully answer your questions as we go along. So moving on then, let's talk about the eligibility criteria. Now, I got to tell you guys, the Specialized Recovery Services Program is not Kim's program. It's not OHT's program. It is Ohio's program. And the way the program looks and the way the program is operated is really a result of collaboration between the Department of Medicaid, the Department of Mental Health and Addiction Services, and our stakeholders. You know, whether it be NAMI or the Board Association or the Provider Association or providers themselves, you know, we had a large group of stakeholders that helped us with this project. And the eligibility criteria look the way they look because of direct input from you. And your colleagues. And so I feel like it's important to say that this is our program. This is Ohio's program that's designed to help maintain eligibility for people who need access to treatment services and recovery services, and then also to give them some nifty new services also. So just wanted to say that. So to be eligible for SRS, you've got to meet all of the eligibility criteria that are listed on these slides that we're going to be presenting on 70 through 73. SRS is for adults, so a person has to be 21. The person has to be determined financially eligible for Medicaid. And again, we talked about this a little bit earlier. The thing to know about SRS is that the financial eligibility allows someone to have income up to 225% of the federal poverty level. So it is a higher income standard than even Group 8. As of today, 225% of the federal poverty level is $2,199. Now, again, that changes. So next year, I'm sure it'll be something different, and they'll make me have to memorize that then. But for right now, that is the income standard. Individuals have to be receiving Social Security disability benefits. So they need to be receiving either SSI or SSD because of a disability. Additionally, an individual has to be diagnosed with a severe and persistent mental illness as set forth in the rule. Now, I will tell you that this is an area that we modified, again, as a direct result of feedback from you all. Initially, the list of diagnoses was pretty narrow, and folks had a lot of concerns that we were being too restrictive with the diagnoses. So we, again, worked as a team and made the determination, because we already have an existing health home program where we had defined SPMI, we decided it made sense to use those diagnoses. And so as a result, we really opened up eligibility to a lot more people, which I think is a good thing. I think we all can agree on that. The next one is related to the ANSA. So the ANSA is a standardized assessment tool that is used in determining a score that is needed in order to be eligible for the program. It is a tested and validated tool. It is not an Ohio tool. It is something that you know, researchers developed. People who are administering the ANSA, while they don't have to be licensed, they do have to be certified. So all of the recovery managers who are administering the ANSA have to go through a certification process to be certified to administer the ANSA. You know, a score is needed, either a 2 in the mental health needs section or a 3 in the life domain section of the ANSA. I have heard some concerns about the sensitive nature of some of the questions related to the administration of the ANSA, and some concerns that it may not be consistent with trauma-informed care. You know, I appreciate those concerns. I again will say that all of the people who are administering the ANSA are required to be certified. The tool itself is a tested and validated tool. I think, you know, we have some research around the tool, and so right now it is the tool that's being used for this portion. I hear people's concerns about that, but for right now, you know, it is part of our criteria and we are required to use that. Doesn't mean that we might not change it at some point in the future, but again, it is the tool is no longer valid if the assessor skips portions of the tool. But we would expect that people be sensitive in the administration of it. So I just wanted to say that. The next criterion is related to demonstrating a need related to the management of their behavioral health condition. The next one is about a risk factor. Again, this is another one where we really modified it based on feedback from you all. Previously, this had been really tight and had very prescriptive lengths of stay related to inpatient stays. And the reality of it is that our service delivery system is such that people don't stay in the hospital for that long. And so we wanted to modernize this criteria to be more consistent with kind of how the world works today. So individuals have to have at least one. Don't have to have them all, but at least one. One or more psychiatric inpatient admission at an inpatient psych hospital. And that's ever. That's in their lifetime. And I will also tell you that this is self-reported. So the recovery management entities are not looking to call the hospital to validate this. If an individual says they had a psych hospitalization, then they had a psych hospitalization. The next one is a discharge from a correctional facility with a history of inpatient or outpatient behavioral health treatment while being in the facility. 2 or more ED visits with a psychiatric diagnosis, or, you know, a history of treatment in an intensive outpatient rehab program for greater than 90 days. There's been some confusion around what an intensive outpatient rehab program really means, but really what we're talking about is, does the individual have a history, or are they currently engaged with the community behavioral health system? So, you know, are they seeing a psychiatrist at the mental health center? Are they getting CPST services? Are they getting therapy services? You know, med management, those kinds of things. That's really what we're looking for. And again, it's self-reported. Additionally, people have to be residing in an HCBS setting. This is a little bit of a, I would say, a hot spot in the SRS program. The Specialized Recovery Service Program is it's a 1915I. I'm Medicaid geeking out on you guys again. So, go look at your Social Security Act. Again, a good time, always. Specialized Recovery Services Program is considered a state plan home and community-based services program. As such, it is required, Medicaid is required to comply with the CMS home and community-based services. They're not guidelines, they're requirements. The challenge that we have is that all of our existing HCBS programs kind of got grandfathered in to meeting these requirements, and so we were able to establish a transition plan where we kind of articulated how we were going to become compliant, but because SRS is new and it was new after the regulations went into effect, we have to be compliant now, basically, in order to operate the program. And so this settings piece is a big piece of this, and I have heard lots and lots and lots of concerns. And again, I have to say, we have met, and I've spent a lot of time with many of you over the past probably 18 months working on this program to talk about the concerns regarding individuals in the system who are residing particularly in an adult care facility. And whether or not an adult care facility is going to be seen as a compliant HCBS setting. The challenge that we have is that it is a setting by setting determination. And so I, Kim at Medicaid, cannot make a declaration that Rick's really great adult care facility is going to be a compliant setting without going through a process of evaluating whether or not that setting meets the requirements. And so we have a process, we have a rule, believe it or not, I know you're shocked by this, we have a form. We're Medicaid, we got a form for everything. So we have a form that recovery managers use to have a dialogue with the individual about their experience in their setting. And that's really what it's about. It is about the individual's experience living in the setting that they're living in. Do they have access to food? Do they have access to visitors, to phone, can they come and go as they please? Those kinds of things. I know it's challenging because if you're operating an adult care facility, you got to have rules or else you're going to have chaos. And so it's figuring out, again, for the person, that the setting needs to be compliant, but there can be modifications for a person based on their individual need, if that makes sense. So if I, Kim, have an issue with having visitors in the middle of the night and it's disruptive to the house, I, Kim, could have a modification for me that says I can't have visitors in the middle of the night because of this specific circumstance, excuse me. But the setting as a whole needs to have a visitor policy that, again, is in sync with HCBS settings requirements. I know that that's really oversimplifying it, and it's terribly complicated, but let me tell you this, and I want to assure you, because our goal really is to get people enrolled in this program. It is not to keep people out. But this part is something that we have to do. It's not negotiable. I can't say to CMS, are you really sure we have to do that part? They don't really let us have the smorgasbord approach to CMS regulations. But what we've decided to do is that before any individual would get denied enrollment in the SRS program, we have and are forming a state-level review team. And so that review team will be made up of folks from Medicaid, folks from Mental Health and Addiction Services, and then actually representatives from NAMI, from the Board Association, from the Provider Association to help us in a HIPAA-compliant manner. specific information will be redacted, but to help us really make sure that we're doing everything we can do to get a person to the point where they can be enrolled in the program. And so that we're being consistent in our application of the HCBS regulations. And so that group has not started yet, but we are looking to start that soon. So just wanted to share that with folks. Folks have to demonstrate a need for a service, right? So you got to need a service in order to be enrolled in the program. You have to be able to have your needs safely met in an HCBS setting. Again, I think this has been an area of concern for folks, just because we know that sometimes folks choose to do things that maybe are not in their best interest, but I think that we all do that sometimes. And you know, this is a requirement of all HCBS programs, so we have this requirement in our waiver program. It is not new to us at Medicaid, nor is it new to us for the people on the local level who are administering this program. The other thing that I have to say is that, again, our goal is to be able to keep people enrolled in the program and to keep them healthy and safe. And so we are not looking to arbitrarily disenroll people from the program because of particular challenges that they may have related to their safety. We want to work with folks, and we want to work with you as our partners in the community and helping to develop plans and infrastructure to help people be healthy and safe. So just wanted to say that. We got to have a service plan or care plan or whatever we want to call it. The person-centered care plan, I guess, is what we're referring to here. And now this is fabulous, just between you and me. I love this criteria because basically what this says is in order to be eligible, a person has to meet at least one of the following. They have to have a need for specialized recovery services to maintain stability, improve functioning, prevent relapse, be maintained in the community, and if not for the provision of the service, the individual would decline to a prior level of need. Or previously had met the eligibility criteria and but for the provision of SRS would decline to a prior level of need. You know, this is a recovery model, and we know that folks, you know, improve. And what we would hate to see happen is someone get assessed, get enrolled, and you know we have to do annual redeterminations of eligibility. Again, that's a CMS requirement. That's not a, oh Kim, you're just invading people's lives requirement. That is a CMS requirement. So we, at the next redetermination, if an individual is really improved, and maybe they don't meet the ANSA scoring, for example, we want to be able to maintain the person on the program because we know that part of the reason why they're doing so well is because they're enrolled in this program, they're getting their Medicaid, they're getting their services, and life is good, right? So this criterion allows us to continue to serve people who had previously met the criteria and no longer do so. So wanted to share that. It's one of my favorites. I think it's swell. So here's a map. I tell people that I was the CHARO of the Specialized Recovery Services Program, and for those of you who are my age, I'm old, you'll remember Love Boat and you'll remember CHARO and how CHARO was a special guest. You know, every couple of months she would come and she'd be on Love Boat and then she'd leave and then she'd come back. Well, that was me with Specialized Recovery Services Program. I would come to a meeting and, you know, they'd ask my opinion and, you know, you ask me my opinion, I'll give it to you. And I would kind of come and go, but was later, as you know, kind of assigned Specialized Recovery Services Program on a more full-time basis, and so I jumped in with both feet. And one of the things that I discovered when I became a star, I guess now I'm Julie, your cruise director, in Specialized Recovery Services Program, is that staff were working on the development of an RFP to procure a vendor to do the recovery management service. And as I started looking at the program and what we were doing and what we were trying to achieve, I thought to myself, well, we already kind of do this because, you know, we operate a home and community-based waiver program here at Medicaid called the Ohio Home Care Waiver, and we have vendors in the community who do eligibility assessments. They do case management, which is basically what recovery management is, and, you know, they help support folks in an HCBS setting. And so what we decided to do was, rather than build yet a new infrastructure, right, for this program, why not build on our existing infrastructure of Ohio home care case management entities to do the recovery management activities at the local level. And so that's what you see on this map is our regions and the recovery management entities in each of those regions. You can see that there are 2 in each region, and it has the phone numbers. I am going to give a little plug while we're here. We're getting ready, I think at the end of the week is when we're starting our BH 201 training. So I'm sure you all are aware that the other thing that's happening is that we're totally redesigning the array of services in the behavioral health system, because why not? You know, I'm super excited about that. I think it's going to be really good for people. And so as such, staff are on the road doing trainings talking about that. And so they have 10 trainings scheduled in the next couple of months. As part of those boots on the ground trainings at the local level, we're actually going to have the recovery management entities there at those trainings. And so during those trainings, there will be a small, short presentation on SRS. There will be locals there. We'll have Medicaid SRS program staff there too. And so the hope is that it will be an opportunity for folks at the local level to connect. And so I just want to give like a little shout out to that. I encourage folks to attend and register. Really great information being shared, and an opportunity, I think, to get face-to-face, to have a face-to-face encounter with the recovery management entities at the local level. So just wanted to give that plug. So there's the map. So let's talk a little bit about how this works and what this process is. So a couple of things. When we were gearing up to go live with Ohio benefits and with our change from 209B to 1634, we started trying to identify individuals who we thought were potentially eligible for the program. And so we did a data search. Now I will share with you, and I know this is shocking, we have challenges with our data. I know. Can you believe it? But we did try to identify or pre-identify individuals who we thought were going to be eligible for SRS. And we actually sent those folks a little letter. We called it the educational letter. You know, it wasn't a NOAA, it didn't have official hearing stuff. It was just, hey, guess what? This is happening, this program is coming, we think it's really great, and you know what, we think you're going to be eligible, and we've assigned you to a recovery management entity, and they're going to be contacting you. And so we did that for about 5,500 people. We also tried to, if the individual was known to the system, and so that meant that we could identify a provider from whom they were receiving services, we told the provider to, and just said, hey, you know, we've sent your person a letter. Now, the challenge with that initial 5,500 group of folks was that most of them were not known to the system. And so these were people who were on spin down who looked like they had a qualifying SRS diagnosis, but who did not appear to be actively engaged in the system. So we then realized that we really needed you, our behavioral health providers, our colleagues in the community, to refer individuals to the program. And so we're going to talk about that again in more detail in a few minutes. The other thing that I want to say here is that people cannot be enrolled in SRS and a 1915C waiver, so passport, home care waiver, IO waiver, or PACE or RSS simultaneously, nor can a person be in a nursing facility or an ICFIID. So just wanted to say that. So again, we pre-identified folks, we let folks know, providers know if we knew of them, and then what happens is we do a random assignment to one of the two, and we use this term independent entity. And so the independent entity is also known as the recovery management entity or case management agency, all the same thing. So that map that we just showed you of those regions with the names, CareStar and CareSource and Council on Aging, those are the independent entity / recovery management entity / case management agency. They're, we use a lot of different words, but all the same thing. Now, people are randomly assigned to those agencies, but they can choose the other one if they want. So, we do allow folks, if they want a different provider, they are allowed to do so. All right, so then what happens once the person is actually assigned to an independent entity? They actually then, that agency assigns a recovery manager. And a recovery manager is basically like a case manager. That recovery manager is responsible for helping to determine if the person is going to be eligible for the program. And so they actually do schedule a face-to-face visit. And it has to be a face-to-face visit. CMS requires that the eligibility determinations happen face-to-face. So the recovery manager schedules the visit, completes the ANSA, they do the assessment of the living arrangement for HCBS setting requirements, they gather information and develop a preliminary service plan. During this process, they are going to be reaching out to you if they know about you. And we're trying to tell them, again, when a person is engaged with a particular provider, to give them that information. I am begging of you, when they reach out to you, please call them back. Please respond to them. Please work with them. One of the things that we're having challenges with is well, there's several, but one is even trying to track down folks. And so sometimes they have a hard time getting a hold of a person. And so I have instructed them that if they are having a hard time finding someone and they know that they're getting services from Rick's Really Great Mental Health Center, that they reach out to Rick's Really Great Mental Health Center to see if we can figure out how to track somebody down for the assessment. The other challenge that we've had is that there's a lot of misinformation about SRS out there, and a lot of people believe that just because a person who was on spin down got converted to full Medicaid, that they don't need to be enrolled in SRS to maintain their Medicaid on an ongoing basis. And that is not the case. If the individual is above 75% of FPL and they're not eligible for Group 8, this is their way to maintain their Medicaid eligibility. And so we really need people, providers and individuals to really understand, that this is needed. And I know it's confusing because you think, well, I called and they said I have my Medicaid, so I don't need it. But it's really about maintaining your Medicaid after your redetermination. And so I need to say that. The other thing that I want to say, I heard this yesterday, was that SRS was a fake program, not a real program. I can assure you SRS is a real program, and so we need help from our community partners to spread the word so that when the recovery management entities are reaching out to people, that we're getting folks engaged in the process. So that's my advertisement. I feel like I'm on my soapbox today. I'm sorry about that. So moving on, then the recovery manager does all of those tasks, and if the person is eligible, then they're going to get enrolled, and happy day. So I want to talk just a few minutes real quick about covered services and provider requirements. This is another OAC site that you all can go and look at. This is a terrific slide that really depicts the services that are available through the Specialized Recovery Services Program. There are three. We already talked about recovery management, which is really a kind of case management activity. The expectation is that everyone will get that. So here's the thing. In order to be eligible for SRS, you have to receive at least one service every month. And we figured the recovery management was that one service. Now that doesn't mean that it has to be a face-to-face visit every month. We do have contact requirements for the frequency that recovery managers are required to see somebody face-to-face, but at least monthly they're going to be talking to the person. And so that way everybody's getting their service at least once a month and maintaining their eligibility for the program. There are two other really swell services that are available, individualized placement and supported employment, and peer recovery support. So the first one that we're going to talk about is IPSSE, and for those of you who really enjoy this kind of thing, here are your procedure codes. We have a procedure code for an initial visit and then a code for ongoing visit. This is billed in 15-minute units. These providers are actually certified by Ohio Department of Mental Health and Addiction Services under the ever-popular provider type 84. We do know that there are providers today who are certified to do this, and what I would ask is if any of you are listening to this, please reach out so that you can add the specialty of IPSSE to your contract in order to be able to provide these services. Oh, I guess it's coming. So we're so organized. All right, moving on. Here is the procedure code for peer. I'm super excited about peer. Just a terrific opportunity to be able to have Medicaid reimbursement for a service that I think is really valuable. Again, peer recovery support providers are certified by the Ohio Department of Mental Health and Addiction Services under that provider type 84, billed in 15-minute units. I don't have the rates here. You all can go look at the rates, but I think you'll find that the rates are quite robust. We talked about recovery management. I'm not really going to go into this. I think you all can look at this, but we've talked a lot, I think, already about the things that the recovery management manager does. What I will say to you is that recovery management is not a replacement for CPST. So the expectation is that the individual is going to continue to get CPST or whatever kind of care management services they're getting from the community behavioral health system along with recovery management. Recovery management is really focused on SRS and the SRS services and keeping somebody eligible for SRS and on the program. It is not intended to supplant care management or case management activities that are happening through the behavioral health system or, quite frankly, through any other system. So you all just look at this in your leisure, big fun. There's the code, Okay, so let's talk about supporting individuals to enroll. And this is super, super, super important. All right, here's the scoop. And I said this already. We sent letters. We started contacting people actually in May to reach out to them to get people enrolled. We pre-identified people. As I mentioned earlier, I know that we missed people. We know that we missed people, and so we need you, our provider colleagues, to help identify individuals who you believe are eligible for the program. And so what we would do is we would ask that you use the referral template that you can find here on these slides, and click on that and it'll take you. We did a nice little template for you that has all of the data elements that we need. If we do not get those required data elements, we can't process the referral. And so if you're sending me you know, a spreadsheet that doesn't have Medicaid billing numbers on it, there's very little I can do with that. So I need that template to be completed completely. So we ask that you prioritize your referral based on the criteria below. Right now, we are really focusing on those people, on those spend down people. Those spend down people who met their spend down at least 1 month between August of 15 and July of 16. And have a diagnosis of a serious and persistent mental illness as described in the appendix of the rule, and who are over 21. That's who we are focused on right now. We want to make sure that those folks get enrolled, so again, come the redetermination, they're not at risk of losing their Medicaid. If you refer other folks, and I know that y'all do because I've seen it, we're actually going to hold those referrals. So when we get this template that you all send to us, what we do is we have a process by which we compare that list of people to a larger spend down file that we have. If the person is on that spend down file, and I will tell you, it took us a little while to get that spend down file right, but we believe we have it right now. If the person is on there, then we do the random assignment to the recovery management entity for the person to be assessed. If they are not, we have received referrals for people who met their spend down 2.5 years ago. Or we've received referrals for people who are already on Medicaid and they're eligible through an existing category. We are holding those referrals at this time. Doesn't mean that we will never assess them, but that's not where our focus is right now. So it would be really helpful to us if you could tailor your referrals to the people that meet the criteria that are described here. I encourage you guys to go and look at this MITSBITS May 23rd issue. It has a lot of really terrific information that I think will be very helpful. I think we talked a lot about this already. Again, I think I just can't emphasize enough the need for you all to really help identify these folks, to get the people who have met the spend down, who have who have fallen into that window, and get those referrals to us. We have received a lot. I think we've received over 3,000 referrals since we've started. And people can self-refer, so we have received some referrals directly from individuals, and we've received some referrals from some other entities. But we're really trying to focus our energy on people who are currently actively engaged with the community behavioral health system, or new people. Right? New Medicaid applications who aren't going to be eligible and are going to need to gain their eligibility through SRS. So here are some additional just informational and educational information. There's a great video. There's a frequently asked questions. The sample letter that we sent out to people is on the website. Here's just a reminder about my Social Security account. How fabulous is that for how folks can get that set up. So just resource information. Want to spend just a few minutes talking about provider enrollment guidance for providers of peer and IPSSE. So Again, providers can add either peer or IPSSE, if they are already enrolled as a provider type 84. And here's instructions on how to do that. You need to contact Ohio Mental Health and Addiction Services at that email, or contact Ms. Monica Peck at the phone number, and indicate that you want to add IPSSE or peer. You need to attach a copy of your Ohio MHAS certificate that includes the certified services being added, and the contact name and the phone number for any follow-up. And again, we have a provider manual, and we would encourage you guys to go and look at that for more detail, but we really need providers. And we really need providers who are already certified to go ahead and raise their hand and say they want to add these services. I'm just going to spend a minute about managed care and MyCare and how it's impacted. There's a lot of, again, concern and discussion around how SRS interfaces with MyCare and managed care. And so I think what you'll find is this very nifty table that talks about who's coming into managed care when. So as you can see, for the most part, most people who were on delayed spin down, who got converted, or people who are newly eligible due to SRS clinical diagnosis are being held out of managed care enrollment to 1/1/18. Which I think is good news. This is a new program. It gives us an opportunity to have some fee-for-service experience before we have huge managed care enrollment. However, it is conceivable that current people, current Medicare, current MyCare Ohio enrollees, or regular managed care folks could get referred and get enrolled in the program. Again, that's not our focus right now because they're already eligible, right? Because they're already in managed care. But after we do this initial lift of spin down people, MyCare Ohio folks could get referred, and if they're found eligible, they could be enrolled in MyCare and in SRS. In the MyCare model, because all services are carved in, including behavioral health, the SRS services would be carved into the managed care payment, and the expectation would be that providers would contract with the managed care plan for the provision and payment of those services. For regular, just good old-fashioned Medicaid managed care, because behavioral health is still carved out, the SRS services would be carved out. And then we do have some expectations around care coordination. So this goes into a little more detail about just the MyCare responsibilities. I'm not going to go through it point by point. I encourage you in your leisure time to take a look at it. As I indicated, we don't anticipate huge enrollment of MyCare members into SRS. And this is just a little summary of our expedited SSI, SSDI, and SRS referral process. We're at the end of our timeline. Woohoo, life is good. Okay. Questions?
Okay, so I'm going to answer some of the questions we received earlier about Medicaid eligibility. So the first one is, understood spin downs could have been met July 1st, 2015 through July 31st, 2016 by ODM. So that July 1st, 2015 date, you could not have met your spin down in July 2015 and then received active Medicaid on August the 1st. So it would have had to have been the 12 months prior to August the 1st. I think maybe where the confusion on this one came in is that initially all these changes with Medicaid eligibility were supposed to happen on July 1st, 2016, but it did get pushed back to August 1st, 2016. So that's probably why maybe at one point you heard the July 1st, 2015 date, but that is not correct. Another question is, what about QMB and SLMB? And those are our impact programs are Medicare Premium Assistance Programs, and those do still exist. So nothing has changed dramatically with those programs. Another question is, so in other words, if a person has SSDI and has an income higher than $733, they do not keep their Medicaid, correct? And that could or could not be correct. It would be dependent on if that individual is receiving Medicare. So if they are not receiving Medicare, if their income is above $733, but it could be below one of our MAGI category income limits. So if they're not yet in receipt of Medicare, they could possibly be eligible for MAGI. However, once they do become eligible for Medicare, they would no longer be eligible for MAGI, and then we'd have to look at our ABD Medicaid categories. And in that case, if their income was over $733, they would be over income for our ABD Medicaid categories. Another question we have is, what about clients that are on Medicaid with SSDI and are getting Medicare in December 2016? There isn't 4 months to process. I believe our recommendation here would be to complete that SRS referral as soon as possible. And remember, this person, if they're going through that SRS assessment process, they would be PTR protected in their current Medicaid category until that SRS assessment is completed. Another question is, they may qualify for QMB or other programs. And again, like I stated before, our QMB, SLMB, and our MPAP categories all still exist. So those Medicare individuals can have their eligibility explored in those programs to see if they're eligible. And another question we have here is, if a client is currently on MBIWD and is adult eligible and has Medicaid, they have, however, had to stop working because even though they have SPMI status disability, they now have some physical issues preventing them from working at that job. They look for a different job to accommodate their physical issues so they can stay on MBIWD. However, after 5 months off work, they learn from their doctor they cannot work at all. So normally at 6 months after stopping their job, they would no longer be eligible for MBIWD. So would SRS be their only option for Medicaid? And when would they apply for SRS so they do not lose Medicaid eligibility from MBIWD? So if this individual's not yet on Medicare, they could potentially be eligible for MAGI. But however, like we stated earlier, if they are on Medicare, they would be ineligible for a MAGI category, and at that time their income would have to be below $733 to continue on the ABD Medicaid category. And again, in this situation, we would recommend that you do that SRS referral for that person as soon as possible. And again, as a reminder, they would be PTR protected in their MBIWD category until that SRS assessment process is complete. And the last question that we have here is, if I apply for SSDI today and it takes 1 year to be approved and my SSDI is approved retroactive for a year, my Medicare would begin with my SSDI. Can I still get SRS Medicaid? Yes, they can, and we would recommend again that that SRS referral is completed as soon as possible. So at this time, I'm going to go ahead and turn the mic back over to Kim so she can answer some questions about SRS.
All righty. It looks like the first question, and maybe Amy, if you answered this, you can tell me, but it was related to if a person is on SSI, they will not need to complete an SRS assessment. So in that scenario, the individual is gaining their Medicaid eligibility through their SSI. A person can be referred to SRS if they are interested in receiving services from the program. But as I mentioned previously, our focus right now is on the spend down folks who are not otherwise eligible for Medicaid under another category. The next question is, if you're doing a standardized Medicaid application, does that also cover SRS? No, you need to apply for SRS separately via that mechanism that we described in the presentation. The next question is about the income limits for SRS Medicaid, and so currently that is 225% of the federal poverty level. For individuals, that's $2,199. I don't know off the top of my head, maybe you do for couples, what the income limit is.
It would be based on, it would still be the 225% FPL, but I believe they're still going to be using their individual income.
Okay, so it sounds like in a couple situation, they're just going to look at the individual's income. They're not going to look at the spouse's income in the determination. So it'll still be the 225% of FPL. The next question is related to an 800 number for a referral. Again, we are asking that referrals come in via the mailbox that we included in the PowerPoint. If you have just one referral, you can just send that referral with the data elements that we're requesting. You don't have to fill out the spreadsheet if you've only got one or two. Go ahead and just give us the information that we need and submit it to the mailbox. What we would ask is that, of course, if you're sending sensitive information, that you send it in a HIPAA compliant manner. So if you, hopefully you all have, HIPAA compliant email that you can send, but if you still need to fax, there are instructions in the MITSPITS around how to do that, how to fax, how to email in a HIPAA compliant manner, all of that. And so we have tried super hard to provide you with all the information that you need. The next question was about a case manager doing an application on behalf of a person. Certainly, we would want you to do that. Again, just follow the process that we've described in the PowerPoint. The next question is about a mid-screen that has some kind of reference to MRDD targeted case management, and what does that mean? I really can't answer that, so this is from Christy. Christy, if you want to send us the information with the specifics of the individual, we can look it up. I have a feeling that probably it's a standard benefit plan that shows up for every Medicaid recipient, and I think that's probably what it is, but without seeing it, I don't know for sure. So if you wanted to send us the details, we can take a look. The next one is about when we have individuals showing active Medicaid admits but not showing a specialized recovery services span, do we need to reach out to the CDJFS again to request the SRS span to be opened? So there have been some challenges around spans, and recent guidance, I think, has gone out to the counties on some changes that we're making related to spans. So I see that this is Melissa from COAAA. Melissa, what I would ask you to do is to reach out to your contract manager so that we can get the specifics of the cases you're concerned about so that we can take a look. The next question was about how many people have been evaluated. We've only heard of 3 in our entire agency, 2 of whom were approved. We have evaluated a lot. I don't know the figures off the top of my head. Maybe somebody who's working with the data here can, but I want to say it's maybe close to 2,000 folks that we've seen so far, and we've approved 1,000, 1,200, something like that. Again, I don't have the data off the top of my head, but we are assessing people, we are approving people, people are getting enrolled. Like I said, we did have some challenges with some span issues, some systems issues. I know you're shocked by that, but we are getting folks enrolled. Did we answer the question about an individual that qualifies for SRS and MBIWD? Which program would they be enrolled in? So I'll tell you my opinion. So MBIWD is a fabulous program, and it actually allows the person to have income and assets beyond what a person on SRS could have. And so depending on how much money the person's making, I believe that MBIWD is the way for the person to access their Medicaid. I don't.
Yeah, I mean, I believe an MBIWD person will be group 1. Right.
Right.
So, you know, if they wanted the extra SRS benefit.
They could do both. They could do both. If they want those additional services. Again, our focus isn't on those folks right now. We're still working on those spin down folks. The next question was about the state being aware that the marketplace insurance doesn't cover CPST, right? Absolutely. That's why we created Specialized Recovery Services Program, was as a direct result of concern about exchange plans, even with mental health parity, being able to provide the robust package of services that are available under Medicaid in order for people to be healthy and safe. And that's why we created the program, and think that it's so important to get people enrolled. So that's the end of my list of questions. Oh, I guess I have more. And we have a few minutes, so we'll get through as many of them as we can. And then know that those that we can't answer right now, we will be publishing the responses at a later date. So the next question, again, this was a span issue. We have individuals showing active Medicaid admits but not showing specialized recovery services span. Do we need to reach out? Again, if these are recovery management entities that are having questions, I would encourage you to work through your contract manager so that we can get these issues resolved. The next question is about the process in which a person who's receiving Medicare QIMBY may have received a Medicaid card after the transition. Can you speak to that?
Yes, that is a known issue with those cards, and they're working on a fix to have the cards, the QMB cards and the regular Medicaid cards differentiated. So that is a known issue at this time, and that did happen. But those individuals, if they were QMB only before, they would still be QMB only now after the transition on August the 1st.
All right, then we're going to do a couple more questions, and like I said, then we will respond to the ones that we did not get to, and we'll make it available to folks online. So the next question was about will the recovery manager determine in their plan if the person is required to receive IPS, SE, or peer? If the person doesn't follow through with the recovery manager's recommendation, will they no longer be eligible for Medicaid? No. I think the thing that folks need to understand is this is a person-centered process. So, you know, I can't say to Michelle, you're going to have peer and you're going to like it. Or, you know, you're going to have IPSSE, you are going to work. So it really is driven by the individual and the individual's needs and preferences. Now, given that, a person does have to be getting recovery management in order to stay eligible for the program. And recovery management, again, is that kind of case managing service. There is a face-to-face requirement with that and kind of a monthly contact, you know, phone call, but the intent of recovery management, again, is really about, you know, keeping people enrolled in the program. So people don't have to accept IPSSE and peer if they don't want it. The next question is kind of a follow-up to that. What kind of services do the recovery managers authorize? And it's those three: peer, IPSSE, and recovery management. And we're going to do one more. We have many people who never applied for Medicaid spin down, even though they may have qualified. Can they apply for SRS? They certainly can. Again, not our focus right now. Our focus is on getting those spin down folks enrolled, but you can feel free to send those referrals in. We will hold them, and then when we distribute those for assessment, we will let you know. So we are going to stop with questions there. We do have, you know, a few more, not tons, maybe 10, 15 or so. So we will work on answering those, and we will publish those answers. I think, are we going to publish all the answers online? We are going to publish all of the responses to the questions online. So, oh, and the recording will be available so you all can just listen to this over and over and over again. I just want to say thanks to everybody for participating. I think this was really terrific, and you guys have a great day. Thank you.